I'll hand over to the team from Bristol Royal Children's Hospital. So it's a huge pleasure to welcome three speakers: Dr. Majumdar, who's been a consultant in pediatric neurology since 2005, specialist interest in movement disorders, spasticity in children, headache, and functional neurological disorders. Also, Dr. Falidah, who is consultant pediatric neurologist at Bristol Children's Hospital, and Dr. Megan Eve, who is Paediatric Clinical Neuropsychologist at Bristol Children's Hospital. So it's fantastic to have the three of you here. I think Arnie is going to kick us off. So take it away, please.
Right. Thank you very much, Jeremy and Hamish. I'm going to share my screen and hopefully it'll work. Right. Jeremy, just tell me if it's working. Yep, perfect. Okay, right. So my name is Dr Majumdar. I'm going to just whiz through some of these slides and give you a bit of an overview talk about FND, functional neurological disorders, and hopefully it will then set the stage for the other two speakers who are going to follow me. So I've had lots of clinical experience in FND, and my particular role at the moment is trying to get a service commissioned by the NHS, and also I'm involved in the British Paediatric Neurology Association initiative to look at some of the research questions in FND. So FND, as you will all probably know, is a complex dynamic disorder at the intersection of the mind and the brain. And I think after the end of the talk, we'll get lots of questions because there are lots of overlaps with pain and chronic pain. Okay, so hang on, slides moving? Yes, perfect. So the overview of the talk, a little bit of background and the history, a little bit about nomenclature. I'm going to talk about the body-mind synergy, as they call it. I've taken out some of the clinical presentations, slides and videos. I think the second speaker, Dr. Falidah, will be doing that. And then I'm going to talk a little bit about the role that the professionals have in dealing with this condition. So there's a number of references. This is one that I used, I think, to understand the history. It's very, very interesting. This is a paper, a couple of came out in 2022. It's a whole series of papers. Daniel Friedman, I think, edited this. And it just talks about how the modern diagnosis of FND describes these sets of neurological symptoms without identifiable pathology. And there's lots of interesting things to learn about it, which you start to understand once you delve into the history. So first of all, you will find a lot of papers talking about not just FND, functional neurological disorder, but talking about functional movement disorders. Of course, you need your brain to move your body. So we tend to use these terms interchangeably. My personal preference is to stick to FND. It's a multi-network brain disorder, is what we believe, and it encompasses a broad range of neurological symptoms. And in the pediatric setting, it's incredibly common. And the more you recognize it, the more you deal with it, the more you start recognizing it. And then you begin to see it almost in everybody you see in clinic. I mean, my personal outreach patch is Gloucester. When I first started, I thought everything was organic pathology. Whereas now, when I do these clinics, certainly the literature says 10% of children presenting to pediatric neurology clinics and up to 20% of children presenting to specialist epilepsy clinic, because non-epileptic attack disorders is said to be quite one of the commonest presentations of FND. In places like Gloucester, and I'm sure places like Doncaster, you know, the incidence is probably even higher. And FND, as we all know, places a substantial, a huge psychological, educational, financial strain on children and their families. And this is a substantial burden for the healthcare system. Okay, so the history of FND is intertwined with sexism because of the name. Previously, it used to be called hysteria. And of course, that comes from, the womb. And it was first described in antiquity by the Greeks. And for over 2,000 years, the conceptualization changed in minor detail, but the core concept remained that this was exclusively a female disease. And it was very interesting because I fell into this trap when I sent Megan a referral, and she pointed out the inherent sexism of my referral, which was quite eye-opening. And then when I looked at the literature, I found I'm doing something that men have done for over 2,000 years. And this illustrates it. There's no female neurologist in this famous picture of Charcot with somebody who was classed as hysterical. Right. Okay. So the old terminology used to be hysteria, conversion disorders, and then in 2013, in the DSM 5th edition, the terms hysterical neurosis and conversion disorder were being used, but they've sort of gone out of fashion now. And what we stick to is FND or FMD. And that is because FND can now be diagnosed based on positive symptoms rather than making it a diagnosis of exclusion. And also, if you look at the latest DSM diagnostic criteria, it's eliminated the need for an underlying stressor or a conflict in the patient's life. And as we know, FND does happen in children. What does history tell us about FND in children? Well, interesting papers from over 100 years ago, predominantly published in American Journal of Medical Association Journal, from over 100 years ago, showed that there were triggers. And this is what we see in clinics still to this day. Triggers such as physical violence from a drunken father, stern teacher, examination at school, extracurricular work, preparing for public performances. Organic disease such as minor injury or illness would precipitate these sort of symptoms. Less likely to have sensory disturbances, amnesia. They say less likely to have convulsions, but what we do know now is that non-epileptic attack disorders are actually probably the most common presentation, and paralysis. But certainly compared to adults with what they used to call hysteria, it tends to be less of these symptoms. There are many other types of functional neurological disorders, such as visual dysfunction, aesthesia, wobbliness, abasia, tics, and lots of visceral symptoms, visceral pain symptoms, and including anorexia. And that's maybe another lecture about whether anorexia is a form of functional eating disorder. They seem to be more common in children, and they also made the point that the prognosis in children seems to be a lot better than adults. And this remains true to the same day. So what do we know of the epidemiology? FND may present in children of all ages. The incidence is higher in the teen years. And in adults, although FND is more common in females and may comprise of about 10% of referrals to adult neurological centers, in children, there is an increased incidence in females during the pre-adolescent and teen years, but in early childhood, the gender distribution is almost equal. And what we've also noticed amongst FND community, and I'm sure there's been a similar sort of epidemic amongst chronic pain, is the increase in these types of problems in children during the pandemic. So what are the risk factors and causations? And the following two slides, I'm going to talk about some of the fundamental problems with FND. So first of all, FND can be precipitated by events, and you've heard through history what can happen. And here's another list of things that we see on a regular day-to-day basis. FND can be precipitated by recent vaccinations, stresses in the family discord, individual life stresses, sexual, physical abuse in a child or family member, school-related problems, medical illnesses, procedures, participation in competitive sport or dance. In some cases, there's no identified precipitating event or trigger factors. And even though the DSM criteria no longer requires identifying precipitating stresses for the diagnosis, one has to be a little bit careful because the identical stresses can cause conditions such as dystonia. And of course, historically, dystonia used to be called hysterical. And until science moved on and the DYT1 gene was discovered, torsin. And of course, now we can treat dystonia with deep brain stimulation. But deep brain stimulation can also be used to treat severe psychiatric disorders, such as anorexia, Tourette syndrome, depression. So as you can see, I'm vacillating on this debate, which has been going on for over 100 years, the body-mind interface debate, a la Descartes and Freud, etc. The other problem is the problem with our services. We know there's a dearth of services for FND, and this is a problem in high-income Western countries. I should say not just Western counties, I should say Western countries, although there is a problem in Western counties, such as the southwest of the UK. No one has a service. No one wants to fund a service. And if you look through the literature, in the North American literature, they are always talking about how major centers in major cities with very high quality neurological services have nothing for FND. But herein lies the paradox. It takes a lot of time and effort, and often these patients, these children, are the most needy in terms of care. But these exact patients get ignored as they are perceived to not have an organic real problem. And that's the sort of problem we're fighting with at all times. Okay, so the next few slides is a very quick run through on how to deliver a diagnosis. What's a practical approach to do with a patient with FND? So again, I've mentioned all this before, the clinical presentation, it's actually very common. There's some adult data which shows that 9-10% of all neurology service admissions would present with FND. And predominantly they tend to have motor weakness, seizure-like complaints. They can have mixed motor and sensory complaints. They have positive motor symptoms, and some of them have positive and negative sensory symptoms. So a lot of this work is taken from the work of John Stone, who's a prof in Edinburgh, and his guide is the one that we use, and it's basically name the diagnosis, legitimize concerns, explain the mechanism, show the patient the exam findings, the positive findings. You may or may not wish to discuss the root cause, and then make a plan. The references are there, and there's some videos there which show some of these examination findings. This is John Stone. His talks are available on Twitter, YouTube, or social media. And he is part of the sort of Bible that we often use for functional neurological disorders, which is the Handbook of Clinical Neurology, written by all the great and good in the field. So, naming a diagnosis. The diagnosis of exclusion mentality is no longer there, although we do fall into it in our clinical day-to-day work, versus a positive diagnosis of FND, which is a rule in rather than rule out, where we find signs, symptoms with supportive clinical features like any other diagnosis. And these are features that can be elicited by a clinician without the need of invasive or expensive testing, usually. Second thing is that you need to legitimize the concerns that what the patients have. So it is actually not very useful to say it's all in your head, it's just anxiety. Gaslighting of our patients essentially invalidate their experience and their trust in us. And FNDs are historically very susceptible to gaslighting. There's no single quantitative lab test that you can do to confirm the diagnosis. So it is a clinical diagnosis. And this is precisely why it makes our advocacy and clinical acumen all the more important. And there's a very clear and important distinction. It's FND is not malingering or factitious disorders. Okay, delivering the diagnosis. This is probably the single most important moment of the interaction with your patient. It needs to be done in a respectful and non-dismissive manner. We find that showing them some of the exam findings, do not withhold the rule-in signs. We like to demonstrate to them the example that John Stone says, if yesterday your right arm was weak and today the left arm is affected, then that means that the right arm feels better and the left can also get better. So these are things that we like to demonstrate in trainable tremor, the Hoover sign, splitting the tuning fork. And John Stone's website has some very lovely videos which you can watch these. Neurology assessment is one of the first steps that these kids tend to have. They often go through a lot of professionals, but I've put this bit in red because it doesn't need to be done by a neurologist or a pediatrician. Anyone with the right training should be able to do this. And what do we do when we are asked to do this? It's an interpersonal task. We have to engage with the family, with the child, so that they can feel heard and respected. You don't need to be a neurologist to do that. It's a communication task to explain findings of the assessment, communicating the diagnosis, and providing information about the treatment in order for the kids to get better. It's a logistical task, organizing referrals and ensuring the treatment is properly implemented. And it's a medical task of making sure you're happy in your own mind what the diagnosis is. And this is where the neurological examination and the medical examination comes in. You don't need to be a neurologist to do that. Anyone with the right training should be able to do that. And finally, explaining the mechanism. Okay, so there are certain ways that we explain the mechanism, and I'm sure you do the same in the pain world. Let the person define their own trauma while acknowledging that around 1/3 of the cases, you may never find a psychological trigger. We also provide common analogies, such as to explain this to kids, and Megan will touch on some of these, such as getting butterflies in your stomach to explain the brain, body, mind sort of interaction. And we often use metaphors. I personally like the sort of software, hardware analogy. Okay, what about discussing a root cause? Well, I don't, because I usually don't know if there is one. So I tend to often defer to our neuropsychology colleagues for this. And again, it's a moot question whether you discuss the root cause. And then finally, what we are good at doing is making a plan. You will find lots of diagrams like this, which essentially talk about the multidisciplinary working. This has to be multidisciplinary. There's no other way of doing this. I often give patients leaflets like this, which are screenshots of the websites that they can go on. Neurosymptoms is John Stone's website. FND Hope is a charity specifically for patients and their families. There is one called FND Friends, particularly active in the southwest of the UK. Then there's some specific ones for non-epileptic attack disorder and other, so they're there. Please feel free to look at them. And then treatment. So I have based a lot of my treatment and a lot of the talks that I give on this particular group of papers published by the group of Kozłowska and Fobian. Their Australian group were probably the closest thing to a service which really know what to do about FND. And I would recommend this paper. It sort of reflects a lot of things that I'm talking about. They have this sort of stepwise approach to treating kids, which you can sort of apply to your own service if you're developing one. There is some data out there. We did an audit looking at the long-term outcome, and we found that 1/3 of our kids had comorbidities and 1/3 weren't doing as good as the literature suggests they are doing in terms of outcome. This is repeated by other studies across the country. So the Scottish did a study. They found very similar findings to us. And again, they noticed that high achievers tend to have this type of problem. They also found that non-epileptic attack disorders and headaches and pain were one of the commonest sort of presentations of this. Similar sort of study in Newcastle. They again found similar sort of findings. This is Megan Eve's work, who sort of decided to do a bit of a pathway on how from presentation to follow-up, maybe the pathway can look like. And then finally, to just finish off, this concept of mind-body synergia. We know FND is probably a pathology of the union of the mind and the body, and it requires attention to both sides. And this can mean that treating some of the other somatic symptoms simultaneously while you're treating some of the mood problems and the psychological issues. You need to have physical therapy, you need to have rehabilitation, and there's a three-way axis really to consider. How do you deal with the body? Well, physiotherapists deal with that. How do you deal with the mind? Cognitive behavioral therapy. How do you deal with both? Well, psychotherapy, treatment for mood and anxiety disorders. So this is how the scheme looks like. So I'm just going to stop there. These are the conclusions. I'm not going to read them out, and I'll hand over in the interest of time to my colleagues. Thank you very much. I'll stop sharing.
Thanks, Arnie. Thank you. I am just going to share my screen. Lovely, thanks. I'm Falidah. I'm a consultant pediatric neurologist in Bristol. Thanks, Arnie, for that. I'm going to just kind of pick up on as a follow-up from some of the points that Arnie made. Essentially, as Arnie was saying, FND and signs and symptoms are poorly understood in children, subject to both under and overdiagnosis, and the diagnostic and management approach is actually quite variable across the country and the world, in fact. There has been historical misinterpretation of the signs and plenty of stigma around it, and that's in particular amongst clinicians as well as the public. And the lack of the standardized terminology is a reflection of that. And I saw a question in the chat about whether actually a lot of this outdated terminology is still being used. And yes, a lot of these terms, non-organic, hysteria, conversion, pseudo-seizures are still very much there in our clinic letters, kind of across from kind of, various health professionals will still use these terms. And terminology point is an important point because it's not just a name, isn't it? A lot of these names have quite negative connotations and are rooted in quite a lot of stigmas, and a lot of them have negative connotations as well, like non-organic or pseudo seizures. So it's saying what it isn't rather than saying what it is, and that has kind of been the problem, really, in how professionals have been speaking about FND, really, across the years. So we're not quite there yet, but I think we are moving forward kind of towards a more standardized terminology. Another term that has been used is medically unexplained symptoms, and again, I'm not particularly fond of that terminology because it just introduces an air of mystery to it, and it introduces the concept that this is a diagnosis of exclusion, really, or something that professionals haven't been able to explain. And
we always went with psychologically explained, Ala.
And I think that the reality is that we may not have all the answers. We may not know exactly why FND happens, but we do know we do know a fair bit about it. And I think kind of moving forward, a standardized terminology is quite kind of important, and also from a coding and data collection point of view. So again, just to pick up on, this is the kind of the model that we look at, and this is again from Professor John Stone's work. Again, this is the kind of model we look at, predisposing factors, which may or may not be there. And again, as a follow-up on what Arnie said, from a neurologist's point of view, at the diagnostic stage, we probably have moved away from focusing a lot on the kind of the psychological aspects of the presentation. And that's, I mean, from a neurologist's point of view in the diagnostic stage. And I think part of that is because sometimes you may not be able to get to the bottom of it really at the diagnostic stage from a neurologist or a kind of a clinician point of view. But also because focusing on that can often give the impression to a young person and their family that you are kind of dismissive of the overall kind of context of this condition, and they may feel that you're trying to kind of pigeonhole it or just kind of put it down to one aspect, which is the psychological aspect, whereas our conversation is more about psychological factors being part of the presentation of FND, which is definitely more complex and multifactorial than this. So there are predisposing factors which include other functional disorders and established neurological conditions such as migraine. And then there's often a triggering event, and we do see that a lot with young people who maybe have had a kind of an injury that's classed as a minor injury as such, with no kind of long-lasting physical damage to the organ, but then they present afterwards with functional motor symptoms. And at times it can be a drug side effect, for example, having had an anesthetic, for example, or a minor head injury, as we said. There are comorbidities that are often there, as a lot of you will know, psychological comorbidities, sleep difficulties, and mobility difficulties. And essentially what happens is that then a cycle happens, essentially, where there is increased introspection, self-monitoring, and that ultimately leads to a top-down distortion of signals. And that is the kind of the model that is accepted, although it is a model we may not understand fully at a biochemical level. However, it is an accepted model. There are perpetuating factors, which are very important, because this is really what the management is about avoiding the perpetuating factors. And feeling disbelieved is one of them. And again, when we come back to the stigma amongst health professionals, we speak about how often there can be an attitude, which is, thankfully that is becoming less and less something that we see. But there can be an attitude of trying to catch the young person out with their symptoms, and sometimes they feel that people may think that they are putting it on as such, or what we call malingering. So feeling disbelieved, the medical uncertainty, so going through tests and then more tests and then more tests to look for causes, can often perpetuate the belief, well, that there is an alternative explanation for the symptoms that is just not being found by these professionals, and so there must be something else going on that I don't know about, and that is again, that can be a perpetuating factor. Again, medication and unnecessary surgery in legal cases, again, this is all based on adult data, so that is something that is seen more kind of on the adult side of things. Another perpetuating factor, which is anecdotal, and I think that my colleagues who deal with young children, young people, will probably accept that parental acceptance of the diagnosis is part of that as well. So it's not just the patient's acceptance of the diagnosis or not accepting the diagnosis, it's also the parents as well. So again, that will play a role in it. And then moving on to treatment, as Arnie said, is basically, it needs to be tailor-made really to the patient. And then you may get a partial recovery or a full recovery, and that really depends on the degree of the FND. And prognosis, although it was thought to be quite positive prognosis in children, young people, we're now learning that it isn't really, with about 1 in 4 children and young people either relapsing or continuing to have functional neurological symptoms into adulthood. That's 25%. So that is significant. It's not most of them, but it is still significant. Again, this is another model based on tics, and tics are kind of an interesting. They're an interesting type of function. Well, functional tics are an interesting type of functional movement disorder, in that they overlap a lot with what we call I don't know if you can class tics as organic, but they are the tics that are seen as typically as part of Tourette's syndrome, which has a certain age of onset and a kind of a certain pattern to it. But functional tics, essentially, the predisposing factors in them could be actually having Tourette's syndrome. So not all tics in somebody with Tourette's syndrome are Tourette's tics. Some of them are functional tics. And again, the functional tics can be precipitated. And a lot of us will remember in the COVID pandemic, the TikTok tics kind of thing, and where there's quite a lot of suggestibility in tics. And functional tics were quite common at the time. Again, there's the comorbidities, and the perpetuating factors is not being believed, not knowing what's wrong. But for functional tics, there's a particular perpetuating factor of focusing on their own tics or seeing other tics. And again, just to run through the myths and facts, this is again from Professor John Stone's team's work, 10 myths about functional neurological disorder. I think we've gone through a lot of these. It's that it's not a diagnosis of exclusion. You can have FND with another neurological disorder. A bizarre presentation in itself does not indicate FND, because there are some rare movement disorders and dystonias, as Arnie was mentioning, that can appear quite unusual. But it's not the unusual appearance that we diagnose FND on the basis of, and we'll come to that in the videos. FND symptoms are, of course, not voluntary. There is a role for investigations. So yes, as part of the treatment, as part of the management plan, we will make a plan for investigations as part of it. It's difficult not to do any investigations, but the often in our approach as neurologists, what we will do is we will arrange well, these are the investigations that we're going to do. This is just to exclude that there's anything else going on. But we often would like to say, well, if we're making the diagnosis of FND, we say, on a clinical basis, we think you've got a diagnosis of FND. We'll do these tests to rule out other causes, and then move on from there. What we're not trying to do is then go back and do more tests, looking for other things after the first set of tests has come back. So there needs to be a kind of a clarity as to what the investigation plan as well as the treatment plan is. And that clarity is very, very important ultimately in the prognosis of these children. Again, another myth is that there's less harm in missing a diagnosis of FND than missing other neurological conditions. And well, it's difficult to say what is less harmful. There is harm, though, in missing a diagnosis of FND. There is harm in diagnosing it as something else, because the longer it takes to reach a diagnosis of FND, we know from adult data, the longer it takes for them to get better. So there is harm in missing a diagnosis of FND. And again, we don't think that it's exclusively a psychological problem, although neuropsychology is very much a major part of the formulation moving forward. However, there are other factors that would also need to be taken into consideration, and that's where the multidisciplinary team approach is helpful moving forward. I'm going to move on in the interest of time to some videos. And again, Arnie told us about a positive diagnosis. So what does a positive diagnosis mean? When we examine patients as neurologists, we usually have pointers in the history or clinical signs that tell us that this is a particular condition. We then move on to doing tests, which we would do for all patients, but also for functional. So these are some of the clinical signs that tell us that something is functional. So again, these are from the literature. This is clearly not a young person or a child, and it's an adult who has a tremor. And a lot of us clinicians, by looking at these tremors, will by gestalt say that these are functional tremors. But trying to break it down, why do we think they're functional tremors? And this is the test that's being done by the physician, is called the entrainment test. So basically, this test is based on essentially the hallmark of the difficulties in FND, which is that in functional movement disorders, the movement disorder is very attention driven. So at rest, this person will have these tremors. And then when the attention is diverted away from the tremor by them focusing on another task, which is trying to match the frequency of bringing the thumb and forefinger together, you see a change in the movement disorder. And that very much is a clinical hallmark of FND. So that is entrainment. And again, as Arnie was saying, we're not trying to catch them out. We're not trying to have a hot moment. You know, we found out this is functional. That's not what we're trying to do. We do this test and we explain to the person why we're doing it. And actually, we tell them the fact that this is very attention driven, and when your attention was diverted away from it, it improved. This could be a technique that you could use for your own physiotherapy. So it's empowering to patients as well. And for people with functional tremors will, for their own physiotherapy, try to employ these techniques to control their tremor. So it gives them a sense of control, and it is quite empowering. And it explains to them as patients, well, and their families, why you've reached the conclusion that you have, really. And then moving on, these are again these from the data adults. So this is again a knee buckling gait. Again, by gestalt, we'll probably think it's functional. But how in your clinic, how do you actually decide that? You do an attention diversion technique. You get them to change their gait. So they got them to run here. And when they got them to run, you could see less of the knee buckling. So you get them to run, to walk backwards, to do a tandem gait. And if you see a change in the pattern, then actually that is suggestive of FND. Again, kind of a caution is that there are some dystonias that get better with walking backwards. So you're not just doing one pattern change, you're doing more than one. So you're getting them to run, if possible, walk backward, do a tandem gait. And you're seeing if it's variable across all these different patterns, then that's more suggestive of it. And again, over here, again, this is another video of truncal sway. Again, what they then do is they then get them to do a tandem gait. and then there is this prolonged sway, is what we call an uneconomic gait, really. So this, again, this wouldn't be typical of what you'd see if somebody had a stroke or multiple sclerosis, because it's uneconomic in the sense that it's probably needing more actual muscle power to be able to balance on one leg than the other. So again, that is this prolonged single leg stance is indicative of that. Now this, again, and this is from the literature, this is a person who actually has Parkinson's disease, and indeed has presented with this dragging of the right leg. And then when they get them to do a, well, almost kind of trying a tandem gait, you see a pattern change. And again, yeah, okay, so I'll just move on in the interest of time. Again, these are all about pathogens. Again, this is somebody with myasthenia gravis who's presented with a waddling gait. So again, the thought process is this secondary to the myasthenia gravis. And then there's the gait there. So what they do is they go on to other tests. Again, it changes a bit with the tandem gait when they move on to other tests, which is other tests for strength in myasthenia gravis. And actually she performs well on these strength tests. So again, that gives you the incongruencies that tell you that this is most likely functional. Again, that's the clinical hallmark. Again, this is a kind of an antalgic gait. It's not very specific, and it's difficult really to get to the bottom of it just by seeing what it is. So again, when running, it changes. Yeah, you can see the change there, and in tandem gait, it changes. The third video, again, this is scissoring. This is scissoring gait, and then again, you can see a lot of the scissoring, and then when you, it disappears when walking backwards. So again, that's the pattern change. The Hoover sign, and again, this is again a sign that we clinicians use when there is any weakness if there's we'll suspect a functional weakness in one leg. This is the patient and this is the clinician. What you'll ask the patient to do is try to lift the unaffected leg with your hand underneath the thigh here on the affected leg. And when they lift the unaffected leg, what will happen here is that there will be a reflex muscle contraction, which will be preserved in functional weakness. And what you often do is you ask the patient to put their hand there, and they can feel the muscle contracting. And that gives them, that tells them that, well, your muscle, it can work. There's no physical damage to your muscle. It's just that basically we use the kind of the software versus hardware analogy and these kind of analogies to talk about how the brain can't access the weak area. Again, this is a functional facial movement disorder. Again, and can we clarify whether this is a functional facial dystonia? Is again by pattern change. So here the clinician asks the patient to do various movements, and yeah, so with a tongue protrusion, the pattern of that dystonia changes. So that says that it's likely to be a functional dystonia. And again, I'll just move ahead in the interest of time. We spoke about tics and how there is quite an overlap between the tics in Tourette syndrome and functional tics. And again, this is, we often signpost to neurosymptoms.org, again, Professor Stone and team's work. A lot of these are adult-based leaflets. However, they can be helpful for young people, and a lot of our patients who we see with FND are adolescents, and they can be helpful for parents as well. We spoke about management earlier, as Arnie had mentioned in the previous talk, and I'm just going to add an additional note in management about physiotherapy principles, just for the physiotherapists who may be in the audience. And there are consensus guidance for physiotherapy in FND. Essentially the approach to physiotherapy in FND is almost the opposite approach to kind of traditional physiotherapy in kind of, for example, conditions like, for example, stroke, multiple sclerosis, neuropathies, myopathies, etc. And a lot of it is hands-off, really, and it's kind of building trust before challenging and pushing the patient, involving the family, definitely. And creating an expectation of improvement is very important, really. And this creating an expectation, it's a lot of us as clinicians, we don't want to promise things that we can't deliver on. And the reality is that we cannot guarantee that they will get better, but we can say that actually most young people with FND, we can say that most young people with FND do get better. So, and we do know that from the data. And it is important to create an expectation of improvement, because that is part of the kind of the education around FND and the kind of moving forward from that point of view. Again, it's a hands-off basically approach really in physiotherapy, early weight bearing, promoting independence and self-management, and focusing on automatic movement rather than controlled movements. Because again, if you've got a weak limb, which is function because you've got FND, the more you think about moving it, the less you can move it. So the answer is diverting the young person's attention away from the weak limb, getting them to focus on something else, and building up more kind of automatic movement and reflex movement and overall function. So it's almost like the counterintuitive approach. There wouldn't be any particular kind of stretching or strengthening exercises to that weak limb, because that's not that, you know, that wouldn't be a helpful approach. We generally say to avoid use of adaptive equipment and mobility aids and avoiding use of splints. However, the reality is that a lot of young people with FND will have come to us already with these things in place. So we need to be pragmatic about trying to wean off it, but also we also very much appreciate that once the mobility aids are in, they're almost part of the system, and it will be a difficult process to gradually wean off. And that's where we need kind of joint work really between our kind of a physiotherapy and occupational therapy teams, as well as our psychology kind of approach really to that, to gradually weaning off it. Again, as Arnie said, the incidence is variable, but actually the incidence that we think the incidence is probably much higher than this, because again, what are these conditions being coded as? You know, what terms are we checking for? I mean, you know, is it medically unexplained? Is it conversion? Or are clinicians just not calling them anything? Sometimes, you know, some clinicians, you know, unfortunately, and that has happened, they may avoid calling it. He said around 1 in 4 persistent to adulthood, and the negative prognostic factors are prolonged duration of symptoms and delayed recognition of their functional nature. So really, the earlier we diagnose, we get a management plan in place, and we move forward, the better for these young people and their families. So I think in the interest of time, I will let, these are the rest of my slides. Thank you. I will stop sharing and I will pass on to Dr. Majumdar. Thank you.
Jeremy, we've got very limited time. How would you like me to play it? I could do my top 5 slides if you want, or we could have longer for questions.
That's lovely. I think just carry on, do your thing, Megan. And
Okay.
I'm aware that a lot of people, if they need to go, they'll go. But for those of us that can stay, we'll stay.
Okay, fabulous. Am I sharing? No. Now I'm sharing. Okay, so I will whiz through some of these slides. I'll skip over some of them. I think I've seen questions about, well, that's all very well, but what do we do? So I'll try and focus on those bits. So just an overview of our service. We're a tertiary neuropsychology service. We don't have any dedicated time for FND. And I think we're kind of slowly developing a reputation as an FND service, just because by nature of the patients we see a huge number of kids with FND, but we don't actually have any dedicated funding to do this. We provide, I'll go on to say, but we provide psychological treatment for children with a neurological diagnosis. So things like adjustment to epilepsy, adjustment to traumatic brain injury, and the kids with FND end up on our waiting list, which is an issue for us, and one that, as Arnie said, we're trying to address. In terms of, and we're a neuropsychological service, but you don't need to be a neuropsychologist, obviously, to do this. This is psychology we're doing. I'd say we do use our neuropsychological confidence in thinking about brain behavior links, and particularly thinking about specific learning difficulties, but any psychologist can do this. So the bits that I think we support with, we like to support diagnoses. So we don't provide diagnoses. I think it's actually very important that our medical colleagues are providing the diagnosis, but we can inform the diagnosis. So we don't necessarily only get involved once the diagnosis has been given. We're very strong advocates for timely discharges from hospital for these children. We don't want these kids being overly medicalized. And historically, I've worked with kids who've remained in hospital for months and months and months and months and months. And it I think feeds into chronicity of the problem. So we're very keen to get kids out as soon as possible. We find that although it's really challenging to provide as a service, front loading the psychological support goes a long way. If we can get in there quickly and get some plans in place, we can prevent things from becoming chronic and escalating, and ultimately save the NHS a whole lot of money, because otherwise these kids are being airlifted sometimes into hospital. Co-creation of a care plan, I'll cover that in a minute. That's one of the main things that we do in our team, is create a care plan with the family and the school. We have our intervention pathway, so we try and cap it at 6 sessions, just because otherwise these kids would stay on our books forever and ever. We have been offering some ACT groups. We've just run our 2nd ACT group for predominantly children with FND, which have been fairly well attended, actually. Those have been online. Onward referrals as required. We also, I think very importantly, try and work closely with our CAMHS colleagues. We've recognised that, well, in our opinion, these are mental health presentations often, not always, but there's always a mental health element, and that should be managed within CAMHS. If we just refer these kids straight to CAMHS, the referral gets rejected. So we find that doing a bit of work with the child, uncovering the psychological difficulty, and then referring for the anxiety, the panic, whatever that is, rather than referring for the FND, works well. And equally, we run a CAMHS drop-in clinic. Some of you may be aware of it, some of you may have come to it, but we work with our CAMHS colleagues to co-work these cases, so that the drop-in clinic works both ways, because we can say, do you think we could refer this kid? And they can say, you've referred this kid, we don't know about X, Y, and Z. I think our links with our medical colleagues put us in a unique position to be able to support. I think it can be very difficult in CAMHS if you've got a kid with non-epileptic attacks who look scary, and actually you need that reassurance that we haven't missed something medically. So it's really important that we are working as a team, I think, which is where this interface between CAMHS and the hospital is very important. And we also run a drop-in clinic, a sort of patient-initiated follow-up. We have half-hour slots that patients can book into once a month, which we find holds these kids, because the ones who don't get better straight away, which is a lot of them, sometimes just a check-in to update a care plan and put them back on the right path is enough to then keep them out of hospital. Otherwise, they're bouncing in and out of A&E all the time and feeling very uncontained. So that's how we've chosen to allocate our resource. I'm not going to go through the case example, I'm afraid. So I've talked about getting involved before diagnosis, and working with our medical colleagues, and ideally being present when the diagnosis is given, because we can then we know exactly what's been explained. Some families get it, a lot of families don't, and actually it's very helpful to make sure that as the medical team, we're all on the same page and we're all singing from the same hymn sheet. It also doesn't matter if the ultimate diagnosis is FND or not, because we're health psychologists, we work with people with health conditions. It's not, okay, well, you don't have an organic disorder, so therefore you have to go and see the psychologist. And I think that's an important dichotomy. We know that these are the kind of some of the experiences of families that people are stuck, that more medical tests need to be done, that they're feeling palmed off. And that comes back to what Arnie was saying about diagnosis of exclusion versus positive diagnoses. Psychoeducation is really important, talking about the mind-body relationships. Anyone thinking about head lice does start getting an itchy head. We know that. Sorry for the head lice, the last thing in the day. But talking about headaches, phantom limb phenomenons, the hardware-software dichotomy that Arnie was talking about, I think is all very helpful. Like I said before, we really try and get kids out of hospital as soon as possible. Again, as Alice said, we try to reduce the number of like mobility aids and things, but actually, if having a wheelchair means that that young person is going to get home and get to school, then I'm an advocate of giving them a wheelchair. I think sometimes some of our physiotherapy colleagues can be a bit too black and white with, well, it's FND, so they can't have any mobility aids. We just have to think carefully about it. I certainly worked with one young lady who bought a very beautiful walking stick, and it very much was part of her identity, and I don't think she was ever going to lose that. So we just have to be careful with how we approach aids, I would say. And getting kids out of hospital, it sounds easy. It's not, when they can't walk and they're falling downstairs, and you know, the family live in a 3-story house and have no, it can be really challenging, actually. So it takes a lot of work and a lot of co-working often to get kids home. So the care plan is something that it's the kind of our primary line of intervention, I would say, within the neuropsychology team. We co-create a working formulation with the family. We describe all of the symptoms, how they can be managed in different contexts, what are helpful responses, what unhelpful responses. We put in bold writing that school don't need to call an ambulance every time someone has a non-epileptic attack. And school need that in writing, because they've got a duty of care to kids. Unless they've got that in writing, then they're going to keep calling the ambulance. So that's very important. We try and provide kind of contingencies. We consider comorbid concerns. So we try and make these care plans in collaboration with the families and the school. And when needed, we will go back to the medical team and get input from them for any clarification that anyone feels like they need. But in general, we create these documents, and they're not rocket science. They usually say things like, stop them from banging their heads, let them, you know, go to the medical room after they've had a non-epileptic attack, for example, and then they're meant to go back to lessons. We do have an agreement section, and I'd say this sort of medical contracting is more important for some families than others. But actually, sometimes we do try and get families to sign these documents, and school to sign these documents, that everyone's signed up. I think children usually are better off, not always, but usually are better off attending school at least part-time rather than being at home all the time. So I usually have the approach of being very firm with, these are the hours you need to be in school, but very flexible with what happens once you're in school. So trying to make life as nice as possible, having the option of going to the quiet room, getting them to school is the first step, and then we can tweak things further down the road if needed. In terms of our outpatient management, I just counted, we've currently got 16 patients with a diagnosis of FND on our waiting list. And I don't know how many are open to us, probably the same again, open to us at the moment. So we do have to be time limited, and we never meet all of the need in that time. Most of the time, I would say we don't do very much psychology, like big P psychology. And I think our trainees and newly qualified are always saying, but but what we're not doing we're not doing psychology. I think it's small s systemic work that we do. It's writing this care plan, it's getting kids back into school, it's providing the psychoeducation. Often by that stage, like I say, we have identified a mental health need and can convince CAMHS to meet that need. A lot of our young people are referred on for family therapy in CAMHS, and we do actually have quite good success because of our co-working with CAMHS teams to get referrals accepted. And as I've mentioned, we've been doing this these groups as well, mostly as a waiting list kind of management plan, so that families are having something, and then we've got the drop-in. So our focus is on quality of life, not symptom reduction, and obviously you guys in pain know that better than most. Again, that's why we don't nitpick over diagnoses. We've got a family at the moment who are convinced their child has PANDAS, and I don't really mind if it's PANDAS or FND. I mind how the kid's doing and if they're in school and what their quality of life is. So getting into arguments about that just isn't helpful. I also had one child whose family were convinced that it was the exorcism that got him better, and if that's what they want to believe, I'll take it. He got better. He wasn't too traumatized, and we haven't seen him again since. So very much value-based stuff, ACT kind of approach is what we follow. We're very biopsychosocial. Again, you guys in pain don't need any explanation of that. Alexithymia is very, very common in these children and families, I would say. So really emotionally illiterate a lot of the time, really struggle to identify internal emotional states. Often quite passive coping mechanisms in these young people. Exaggerated responses to strong emotions. In terms of psychological factors, attachment, so these children are likely to be this kind of type A+, so they're very good compliant kids, and they say everything is fine, and they're very helpful, and they don't want to cause trouble, and they carry on smiling. Basically, if a child tells you they're fine, they've probably got FND. And it becomes very difficult within the system, an alexithymic system and child. It becomes very difficult for the child to get their needs met, other than potentially through these physical illnesses. So Arnie and Alan kind of touched on these kind of predisposing factors. In my experience, it's a cumulative impact of small stressors and poor coping systems, which result in FND. So we know that educational transitions, we get a huge influx kind of in October time, I would say, because children have started secondary school and had a chance to find out it's quite hard, or they've started their GCSE courses, or mocks are coming up. Huge number have unrecognized learning needs, specific learning difficulties. So we do cognitive assessments as part of our intervention sometimes, because actually if that's part of the problem, then identifying that is going to be more helpful than giving them 6 sessions of CBT and then sending them back into a classroom where they still can't read because they've got undiagnosed dyslexia, for example. They've usually, but not always, had a period of illness or some kind of injury, some kind of family disruption, potentially, often, but not always, some difficulties with peers. We know that there was the lockdown effect, and it's still really important to consider the age of the child at lockdown, I think, in any formulation. We see a lot of children who have quite high pressures from a sport or extracurricular activity. A lot of them seem to do drama clubs or sports at high levels, dance, high expectations from the family. So just thinking about kind of precipitating factors, we know that there is often, but not always, an element of secondary gain for these, and it's not a term I like very much, but I can't think of a better one right now. but thinking about the role of the child within the family, it's not uncommon that it's the youngest child who's kind of growing up, and actually this illness can keep them in that kind of child role, which can be beneficial for both the child and parents. So that it's all important to consider in terms of systemic formulations. Biological factors. So after having these discussions with Arnie about inherent like issues of bias against women in this diagnosis, I'm actually come all the way back round. We know that rates of FND are much higher in women. I'm really interested in the very high number of patients I'm seeing at the moment who I'm fairly sure have undiagnosed gynecological conditions, and they're often the young ladies who I don't have a very good formulation for. I can't, you know, they've got stuff going on, but it doesn't add up in quite the same way as it does with some others. And I think there is an underlying endometriosis or polycystic ovary symptoms, and the GPs fob them off. As we know, it takes, is it still on average 10 years to get a diagnosis? So I'm very interested in the impact of puberty, the impact of gynecological issues on, and that interaction with FND. We see quite a lot of girls as well who have early onset puberty and then develop FND. Again, there could be psychological factors within that, as well as more biological kind of hormonal underpinnings. As was mentioned in the chat, I think a significant majority of our patients with FND have undiagnosed autism. That seems to be a very, very high group, but it's not all of them, which is really important to say. And certainly the overlap with eating disorders is something that we see as well. So I think considering the biological factors, as I'm sure you very much do in pain as well. I won't go through this loads, but this is a model that we really like using, and I don't know if you guys have come across it in pain. It comes from Kozlowska, who Arnie's mentioned before, who's done loads of really great work in FND. But this castle with these different elements of thinking about the circadian clock and sleep, thinking about pain, HPA access, autonomic motor system, and explaining to families that the brain is in a period of kind of chronic stress, and that treatment is to respond to this, and explaining why, therefore, children with FND are more likely to develop a chronic pain presentation, for example, which is a very common symptom that we see. We find that families engage really well when we go from quite a biological perspective, and this castle formulation supports that very well. So I think that's my main points, and I'll leave it there.
Thank you. If you could unshare your screen, Megan, then we can shift to questions. We've gone a little bit over then, but that's been because we've had absolutely loads of cool stuff. So I'm going to pick up. We've had a really lively chat, and thank you to the presenters for responding in the chat. So I think some questions have come up already, but let me just go through a handful of things that people have mentioned. So I know somebody from our service was curious, Arnie, if you're still there, about the third of comorbidities you found in your follow-up group. And we've talked about comorbidities around autism, neurodevelopmental comorbidities, gynecological comorbidities. Anything else you could say around the comorbidities?
I mean, the things that I've put in the chat are the commonest, but I think sometimes you get multiple comorbidities, and exactly, it sort of links to another question that, why is it that some people present with a non-epileptic attack disorder, others present with a limb not working? We just don't know. My personal way of thinking about this, and how are we going to sort this? I feel, and this is a research question, is you need to have big cohorts, and you need to compare those cohorts to normal children. So we're lucky here in Bristol. We've got the Gene Golding Institute, who have been looking at the children of the 90s. My thought was to consider doing a longitudinal study looking at a cohort where you compare those affected, you age and sex match controls. You use the data from the children of the 90s to try and work out what it is that's going on, because I don't think we really know.
Thank you. And just moving on, I mean, I think one of the things we don't know is, you've mentioned the lumping and the splitting, whether this is all one set of disorders or whether there are quite different mechanisms. I saw some data at a pediatric conference towards the end of last year that kids going through chronic pain treatment with sort of more positive motor FND symptoms like tremor or tics seem to do okay, and with more negative sensory symptoms, I've lost my arm, I've lost my leg, seem to be getting slightly poorer outcomes. They were very early data, but any comments on the sort of different types of FND, and are any easier to treat or harder to treat in your experience?
I think you need Megan for this one.
We should bring Megan in.
So I don't think there is an obvious clear answer to that. I certainly feel that the easier to treat group actually are the ones where the parents understand and are on board with the diagnosis. To me, that's the most kind of confident predictive factor. So when the whole family system is very alexithymic and they're still doctor shopping and they're all very anxious, there's less scope for a young person to maybe improve. So I think when a young person's symptoms seem to be fueled by an undiagnosed autism, sometimes if the parents are on board with this, getting their needs met, I am always hopeful that that's going to have a more positive outcome than these children for whom it's way more systemic. And I think that's the same with any kind of psychological presentation, right? But I think I would say it's that more so than the symptoms, because the symptoms change. Like, you know, it could be a child who's not walking one day, but then they develop non-epileptic attacks, or when you actually take a good history, they've had chronic pain for a while and then they stopped walking for a while and now they've got and it turns into a gastro problem and then they can't see. So actually focusing too much on the symptom itself, I think isn't helpful.
There's also another aspect, if I can just butt in for a second. So you've got changing symptoms, multiple different presentations, multiple comorbidities, and then the interventions that you're giving, none of it it's not like taking one pill where you're going to get one drug at a certain dose. Each neurologist or each pediatrician who interacts with this child and this family have a different way of dealing with it. And we know that talking to these kids does do something for them. And then there are different techniques that people use. So even if you had a case age and sex match cohort, you're never going to be able to compare like with like, because the presentation and the treatment are all so nebulous. I don't know. What do you think? That was just off the top of my head.
I just wanted to also add something to that, Arnie, is that it's also kind of the length of how long this symptom has been experienced for that really makes a difference in how successful you're likely to be treating it. Because I think FND is, in a way, with functional sensory symptoms, it's been thought to be almost the opposite of phantom limb syndrome, and that can be a very entrenched cycle. And that's why you've got in adult FND world, you've got adults who've been experiencing functional sensory symptoms for years and years, and that can be it's a very difficult cycle to break, I would imagine. So I think it's also often when we see these patients, the longer they've had the symptoms, I personally feel less confident about how quickly we're likely to be able to overcome it.
Thank you. We'll begin to round up with the last couple of questions here. We've all talked a lot about autism. Any conjectures about what or why there is a connection? Is it the alexithymia? Is it that, you know, kids with autism tend to be poorer at emotions, therefore they have FND? Does it work like that? I also noted in one of your slides there was something about a increased introspective self-monitoring, whereas I would say a lot of our kids with FND are quite bad at body awareness and quite poor at turning their attention inwards. Sorry, that's multiple questions, but mechanisms, autism, and self-awareness.
Yeah, I'm sure Megan will have a more useful comment to say, but I'm just going back to the kind of that slide with the mechanism of kind of the increased interoceptive kind of self-awareness. My take on that is because a disorder of interoception has actually been implicated in pathophysiological mechanism of FND, is that is a disordered interoception as such, is my reading of it. And we do know that disordered interoception is kind of linked with alexithymia and is overrepresented in kind of autism spectrum disorder. So I think basically what is being said is that in the underlying the pathophysiology is a disorder of interoception rather than kind of healthy interoceptive mechanisms. But I'm sure Megan will be able.
I would agree, Ella. I think it's catastrophic misinterpretation of some symptoms and complete detachment from others. I work with a lot of young people with non-epileptic attacks who will never have a conversation about them. They say, well, I don't know anything about them. I'm not aware of what happens when they happen. And they can't go there. But actually, sometimes if you really, really unpick, you can kind of identify mild prodromal sort of symptoms that they can then recognize and over time learn to get control over their non-epileptic attacks, or at least get themselves to a medical room before they have a non-epileptic attack, for example. With regards to the link with autism, I mean, it's a good question. And I think for me, a bigger question is how does this interact with in Bristol, 5-year waiting list for a diagnosis and chronic underfunding in support for these young people in school, increased amounts of exclusions of children with these needs who are going unidentified. And it does feel like we're seeing more children with FND presentations and undiagnosed autism than I certainly feel like I was, 8-10 years ago. So I think there's a lot to unpick there, but I do also personally think that this ASD kind of population of young people with FND is distinct to some of the other populations.
Oh, there's another topic for research. Now, guys, I'm going to bring us to a close. We've gone over a little bit, but that's because it's been great stuff. So thank you very much to our 3 speakers. It's an absolute delight that you guys came and talked to us and gave some just really great talks. Thank you. For everybody else who's on the screen, we will send out a post-event email. This will have a link to the recording. So if you didn't get to a bit, or you knew that you got a colleague that didn't quite make some of it, then by all means share that. We will have more things coming up. It's quarterly, so keep an eye on X or Twitter if you can bear to, or failing that, drop us an email and get on our email list, or keep an eye on our webpage. So thank you so much to the speakers. Thank you to everybody else, and I'll bid you a very good evening. Good night.
Thank you very much for having us.
Bye.